Good day, everyone, and to continue our lecture with our common diseases or cases we might encounter in our community pharmacy, we're going to talk about women's health. So, in women's health, we will be covering all common conditions in which may afflict our women, in which they are treatable, or in which they could present themselves inside the pharmacy. We will only cover specific conditions related to women. Okay, so to start, women have unique healthcare needs ranging from pregnancy up to menstrual disorders. Most of these conditions are outside the remit of community pharmacists, and most of the time, a specialist is needed. However, a small amount of conditions can be adequately treated over the counter provided that an accurate diagnosis is made. So, in this lecture, after you finish reading through this, you should have sufficient knowledge to diagnose common women's health problems and to treat and counsel our patients in these problems. So, with all conditions that present themselves inside the community pharmacy, it is essential to take an accurate history from our patient. However, the patient might feel uncomfortable or embarrassed, especially about discussing the symptoms in a busy pharmacy. So, what you can do is go to the patient counseling corner and discuss the matters there. Male pharmacists might encounter that the level of embarrassment is especially heightened. So, as a male pharmacist, you might not be the best person to handle cases like this one. So, if there's a female pharmacist, you could I think it would be better if you could refer that to your colleague instead of you asking for the patient's history. However, if you're alone, try to do it professionally. So the first case is cystitis. So cystitis, or our urinary tract infection, is a very common condition that is encountered by women. So cystitis literally means inflammation of the bladder, although in practice, cystitis refers to inflammation of both the urethra and the bladder. Before moving on to discuss cystitis in women, it is important to point out that men, although uncommon, can also suffer from cystitis. So, urinary tract infections are one of the most common infections treated in general medical practice, and it will affect 15% of women each year. Patients aged 15 to 34 will account for the majority of cases, and it is estimated that 50% of all women will experience one episode of cystitis in their lifetimes. So UTI, or urinary tract infection, is a very common condition that may be encountered by female patients. So certain factors do increase the risk of UTI, and it might be helpful when performing history taking of our patient. So in young women, frequent or recent sexual activity may cause UTI, since intercourse can tend to push bacteria inside the vagina and towards the urinary tract. Next is previous episodes of cystitis, use of diaphragms and spermicidal agents, advancing age, and diabetes. So most infections causing cystitis is due to the normal flora of the women, in which it ascends from the perianal area up to the urethra. So bacteria are transferred where they proliferate, and the most common bacterial organisms that cause cystitis is your E. coli and your staph and proteus. So when should you arrive at a differential diagnosis? Most of the time, patients who come into the pharmacy will have acute uncomplicated cystitis and have accurately made a self-diagnosis. The pharmacist's aim is to simply rule out other more dangerous conditions and identify patients who are at a risk for complications as a result of cystitis. So the clinical features of cystitis is it is characterized by pain when passing urine, more nocturia, frequency of urination, urgency of urination, and hematuria or blood in the urine. The diagnostic probability of cystitis is over 90% if patients exhibit dysuria or they have pain while urinating, even without vaginal discharge or irritation. In addition, the patient might report small amount of blood in the urine, which patients might also present themselves with small amount of urine that may pass and pain worsening at the end of urine. Symptoms usually occur suddenly, and suprapubic discomfort or puson is not associated with passing urine, might be present but is not common. Hematuria or blood in the urine is relatively common but should be treated with caution since it may be a sign for a tumor or it might be a sign for kidney stones. So if there is presence of blood in the urine, most cases should be referred. So some conditions to eliminate. So pyelonephritis is one of the most common complications of cystitis. It's when the invading pathogen climbs up to the ureter or the kidney, then causes infection over there. Most of the time, the patient will show systemic signs and symptoms like fever, chills, flank pain, loin pain, and possibly nausea and vomiting. Other more unlikely causes could be STDs caused by a number of pathogens, including chlamydia and gonorrhea. Symptoms are similar to uncomplicated cystitis, but they tend to be more gradual in nature and last for a longer period of time. In addition, pyuria or pus in the urine is usually present. So these are samples of gonorrhea, and this is chlamydia in females. Another less common condition you should look out for is your atrophic vaginitis or estrogen deficiency. So this is more common in postmenopausal women as it results to the thinning of our endometrial lining as a result of reduction in the levels of circulating estrogen. With the decreased levels of estrogen, this decreases the likelihood or trauma leading to cystitis. Okay, so it lessens the lining. If the symptoms are caused by intercourse or sex, symptomatic relief could be gained from using a lubricating product like your KY jelly or your easy lubricating jelly. Very unlikely causes is medicine-induced cystitis. It is common in non-steroidal anti-inflammatories, so ask the patient if she has taken any recent medications. Vaginitis should be also questioned when there is an associated vaginal discharge. The presence of vaginal discharge is highly suggested of vaginitis, and referral is most likely needed. So here on the screen is the trigger point for cystitis. Please take note that if a male presents with cystitis, it's for referral. So evidence for over-the-counter medication. So cystitis is best treated with antibiotics. And since you can't give antibiotics without a prescription, most of the time it's up to referral. So you could probably use alkalinizing agents. However, data is currently scarce and it does not support the use of alkalinizing agents. Cranberry juice is also a popular treatment for UTI. However, similar to alkalinizing agents, they have little to no clinical trials performed, or the data is insufficient to establish its use. Next you have is vaginal discharge. So most So women might present themselves with vaginal discharge. Most of the time, they will present themselves with vaginal discharge if it has an odor or it has a bright white color, like what you see on the top right of the slides. So patients of any age can experience vaginal discharge. The three most common causes of vaginal discharge is bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. As thrush, or our vulvovaginal candidiasis, is the only one that could be treated over the counter, we will be concentrating on this type of vaginal discharge. So for prevalence and epidemiology, it has been reported that sexually active women have a 75% chance of experiencing at least one episode of thrush during their childbearing years. In adolescents, it is the most common cause of vaginal discharge after bacterial vaginosis. So, in the etiology, since in the vagina, the vagina naturally produces a watery discharge or a physiological discharge that acts as a lubricating agent and also protects the vagina. So the amount and nature of this discharge varies depending on many factors such as ovulation, pregnancy, and medication. At the time of ovulation, discharge is greater in quantity and of higher viscosity. Please take note that the key characteristic of normal vaginal fluids is that they have no odor. The epithelium of our vagina contains glycogen, which is broken down by enzymes and bacteria. This maintains a acidic vaginal pH, so that's the main reason why you use pH care or any vagina-specific product in creating an environment inhospitable to pathogens. The acidic pH creates the acidic environment is managed by the concentration of estrogen that produces glycogen. So if estrogen decreases, glycogen then also decreases, then it leads to a less acidic environment in which our opportunistic pathogen like our Candida albicans can take infection. So when arriving at a differential diagnosis, many patients will present themselves with the correct diagnosis, and it's only your job to confirm that diagnosis. Misdiagnosis is important because self-diagnosis of patients is common and dangerous. Bacterial vaginosis, meaning it's a bacteria, not a fungus that infected, is linked with pelvic inflammatory disease and delivery of low birth weight infants and trachomitis, and the other one can cause infertility. So it might be good for referral. So the symptoms of pruritus or itching, burning, and discharge are possible in all three causes of vaginal discharge. Therefore, no symptom can be relied on with 100% certainty. Asking symptom-specific questions will help the pharmacist to determine if referral is needed. Okay, so if you can describe this, that represents your vaginal discharge and probably a severe Candida albicans infection. Okay, so here are some specific questions to ask the patient. So any discharge with a strong odor should be referred. Bacterial vaginosis is associated with a white discharge that has a strong fishy odor. While for trichomoniasis, it is a malodorous, meaning it still doesn't smell good, with a green-yellow discharge. In contrast, fungal infection is described as curd-like or cottage cheese-like with little to no odor. Clinical features of thrush is that the dominant feature is vulval itching. So let's scratch it down there. This is often accompanied with discharge, and the discharge has little to no odor with a curd-like consistency. Symptoms are generally acute in onset. Okay, so some conditions to eliminate. First is your bacterial vaginosis. This is the most common cause of vaginal discharge, and in a community pharmacy setting, it must be eliminated first as a cause of the symptoms. Approximately half of the patients will experience a thin white discharge with a strong fishy odor. Odor is usually worse after sex and may worsen during menses. Itching and soreness are not usually present. So our next condition is trichomoniasis. So trichomoniasis is a protozoal infection that is primarily transmitted through sex. If symptoms are experienced to be a profuse, frothy, green-yellow, and malodorous discharge, accompanied with vulvar itching, it is typical signs of trichomoniasis. Next condition to eliminate is our cystitis. So dysuria can affect 1 in 3 women with vaginal infections. However, the patient will often be able to sense that there is an external discomfort rather than a internal discomfort located in the bladder. So the sign here is near the exit of the vagina is where the pain is originating, not near the flank area. Atrophic vaginitis can be also eliminated if the symptoms consistent with thrush, especially in vaginal itching and burning, may be due to atrophic vaginitis. However, clinically significant atrophic vaginitis is uncommon in postmenopausal women and should be referred to rule out malignancy. Thrush could be also induced by other medicines like broad-spectrum antibiotics, corticosteroids, immunosuppressants, and medicine that may affect estrogen status of the patient. It is therefore not unusual to see a patient being prescribed at the same time as receiving antibiotics. So also check with our patient if she is taking any other medications. Diabetes could also be a cause for thrush, since patients with poorly controlled diabetes are more likely to suffer from thrush because hyperglycemia can enhance production of protein surface receptors on Candida albicans organisms. This hinders phagocytosis by neutrophils, thus making thrush more difficult to eliminate. Pregnancy can also cause hormonal changes in the vaginal environment, causing the eradication of Candida to be more difficult. Next, we have chemical and mechanical irritants. Take, for example, feminine hygiene products like bubble baths, vaginal sprays, douches can precipitate attacks of thrush by altering vaginal pH. Condoms have been also found to irritate and alter the vaginal pH, especially if you use special condoms. Next, you have recurrent thrush. There is a minority of patients that will present with recurrent symptoms. Recurrent thrush is classified with 3 or more episodes per year, and it might be a sign of poor compliance with antifungals, a misdiagnosis, resistant strains of Candida, or an undiagnosed diabetes, or even a mixed infection. So here are the different trigger points indicative of referral for vaginal thrush. So evidence base for over-the-counter medication. So you could go 1 or 2 ways. You can use topical antifungals, or you can also use an oral antifungal. So imidazoles and triazoles have been proven and have comparable efficacy with clinical cure rates between 85 to 90. Additionally, cure rates between single or multiple dose therapy and multiple day therapy show no differences. So you can use a number of formulations like creams, vaginal tablets, and pessaries. All internal preparations should be administered at night, and this gives the medicine time to be absorbed, which eliminates a possibility of accidental loss, which is more likely if the person is mobile or standing. However, please do take note, the things you see on the screen right now are the common dosage forms for your vaginal thrush. Please do make sure that when you give patients this type of drug, you are to accompany it with a lengthy discussion on how to properly administer the medicines. These are not common drugs that everyone knows how to administer. So you yourself should be able to discuss how to administer these drugs to yourself if you had a vagina. Next is an oral medication, which is diflucan 1, and this is the only one I found in the market, or Canesten oral. Fluconazole is a single oral treatment that can be taken any time of the day, and it's only a single 150 milligram tablet. Next condition we will be talking about is primary dysmenorrhea, or basically period pain. So I think most of you are familiar with period pain. Menstruation spans the years between menarche to menopause. This is approximately 30 to 40 years, starting at around 12 and ends at around 50. The menstrual cycle usually lasts 28 days and varies between 21 to 45 days. Dysmenorrhea is usually categorized as primary or secondary. Primary dysmenorrhea has no cause, while secondary dysmenorrhea has an underlying cause. So, primary dysmenorrhea is common in adolescents, but exact rates vary because there's difficulty in defining what is dysmenorrhea and how painful should dysmenorrhea be. So, the cause of dysmenorrhea is overproduction of uterine prostaglandins E2 and F2 alpha, and this contributes to painful cramps. Prostaglandin production is controlled by progesterone just before menstruation starts, and progesterone levels decrease, allowing prostaglandin production to increase, and if overproduced, cramps can occur. So here are specific questions to ask the patient in primary dysmenorrhea, and particularly age. Adolescence is the main population that experience primary dysmenorrhea. That's why, if you recall in your high school years, there's a lot of female classmates that go to the clinic. It's because they probably have dysmenorrhea. So the nature of pain can be also used to differentiate PD from secondary PD, in which for general primary PD is cramping, while for secondary dysmenorrhea it's more of a dull ache. Severity is also considered, and with onset of pain as well. Clinical features of PD is the typical presentation is lower abdominal cramping shortly or up to 2 or 3 days after the onset of bleeding. Commonly associated symptoms include fatigue, back pain, nausea, vomiting, and diarrhea. It is classically associated with young women who just have started having regular periods. This is due to as many as 50% of women being anovulatory in the first year, and it is important to know as anovulatory cycles are usually pain-free. So some conditions to eliminate. First is secondary dysmenorrhea, for example, is endometriosis. So endometriosis is the presence of endometrial tissue outside the uterus. The exact incidence is unknown, but it is the most common cause of secondary dysmenorrhea. Any person over the age of 30 either presenting for the first time with dysmenorrhea or has experience worsening symptoms of dysmenorrhea should be viewed with caution and most likely be referred. Patients experiencing lower abdominal pain, aching rather than cramping, and it is 5 to 7 days before menstruation. The pain often peaks on the onset of menstruation, and referred pain into the back and down the thighs are also possible. So when we say referred pain, it is pain that radiates away from the main source of the damage. Unlikely causes to eliminate is your PID, or your pelvic inflammatory disease. It is an important cause of infertility and ectopic pregnancy, with many women being asymptomatic and only being detected during infertility investigations. And you will not most likely encounter this. You can also you might also eliminate dysfunctional uterine bleeding. It is a non-specific medical term defined as a abnormal uterine bleeding that is not due to systemic or structural diseases, and includes conditions such as amenorrhea or lack of menstruation, menorrhagia, which is a heavy periods, and majority of cases attributable to menorrhagia. Pharmacists should ask the patient if their periods are different from usual. Evidence-based for over-the-counter medication, NSAIDs. The use of NSAIDs would be a logical choice since raised prostaglandin levels cause PD, and multiple clinical trials showed effectiveness of 80 to 85%. However, there is no evidence for any superiority of any individual NSAIDs. So mefenamic acid, ibuprofen, or celecoxib, it will work just fine. Be careful of marketing. Midol is usually marketed as treatment for PD. However, it's just the same as other ones. Hyoscine and butylbromide, or Buscopan, is also currently being marketed to treat PD. However, during a study to 17 patients in a crossover trial, the study failed to demonstrate any significant effect compared to placebo. However, in the author's opinion, it was good to as a alternative to NSAIDs. Please do take note that Buscopan Venus and Buscopan Plus are the same drug, which Venus is only pink. Women tax. Low-dose combined oral contraceptives are not available over the counter, especially here. Other treatment options, you could go for something more physical, like transcutaneous electrical nerve stimulation, acupuncture, exercise, and dietary supplements. Out of this, high-frequency TNS have the greatest body of evidence to support its use. So in summary, for treating primary dysmenorrhea, NSAIDs are your drug of choice, or the drug to go. If the patient does not improve after 2 to 3 dosing of NSAIDs, it's time to refer. Because after the first dose, there should be a marked improvement in the cramps. Next condition we will be covering is our premenstrual syndrome. So here's a meme for everyone before we move on. So PMS, or premenstrual syndrome, is a broad term that encompasses a wide range of symptoms, both physical and psychological. Symptoms can range from mild to very severe, especially mood symptoms, which can affect patients and can interfere with day-to-day functioning and relationships. In these women, a diagnosis of premenstrual dysphoric order is given if it is more psychological. So the exact prevalence of PMS is hard to determine because of the varied definitions of PMS, and there's a large number of women who do not seek medical attention. There appears to be no marked racial or ethnic differences in the prevalence, but age appears to be a risk factor. Most women tend to be over 30 years old. The exact pathophysiology of PMS is unclear. However, there are a number of theories. Most researchers now believe that PMS is a complex interaction between the ovarian steroids and the neurotransmitter serotonin and GABA. It is important to focus on one cycle symptoms but ask the patient to describe their previous symptoms over previous cycles. A diary could be useful or if built over 3 cycles and maintained for a fuller picture for it to be elucidated. Asking symptom-specific questions will help the pharmacist to determine if referral is needed. So here are common symptoms of PMS. So you have physical, behavioral, and mood. Okay. So physical are easy to distinguish. However, behavioral and mood symptoms are harder to detect, and they could only be answered by the patient. So some conditions to eliminate is primary dysmenorrhea. So cramps and suprapubic pain might be experienced by PMS sufferers, although these symptoms are uncommon. Key distinguishing features between PMS and primary dysmenorrhea is that PD does not have any behavioral or mood symptoms. And in primary dysmenorrhea, the timing of the symptoms is within menstruation, while premenstrual disorder or premenstrual syndrome is before the mens. So here are some specific questions to ask the patient in terms of premenstrual syndrome. Now, the key thing you should be able to cross-diagnose is mental health disorders, since PMS would most likely cross mental health disorders in terms of their symptoms. Depression and anxiety are common mental health disorders which can often go undiagnosed and can be encountered by community pharmacists. Patients with PMS might experience symptoms similar to these conditions, such as sad mood, loss of interest, loss of pleasure, and anxiety or worry. However, to differentiate this from depression and anxiety is that in PMS, it is cyclical. It comes and goes with your natural cycle. And there is no physical symptoms such as bloatedness and breast tenderness. And our final case, or our final condition, is menorrhagia, or a large amount of vaginal blood, menstrual blood. Okay, so the NICE guidelines defines heavy menstrual bleeding, or HMB, as excessive menstrual blood loss, which interferes with a woman's physical, emotional, social, and material quality of life, and can occur alone or in combination with other symptoms. Blood loss can be measured and is used in research. However, in normal day-to-day scenarios, it's hard to measure menstrual blood loss. So typically, it will classify as heavy menstrual bleeding if you lose 90 milliliters of menstrual blood. However, this is the blood loss category or classification, and you can actually safely donate up to 473 milliliters of blood. So 90 ml should have no physical you should have no physical symptoms when you lose 90 ml of blood. So where does HMB come from? There is usually none. Approximately half of cases have no identifiable cause that can be construed for HMB. Identifiable causes can result from uterine or pelvic pathology, systemic disorders, and other iatrogenic factors. So here are some specific questions to ask the patient for heavy menstrual bleeding. So the clinical features of HMB is obviously blood loss, particularly blood loss that is perceived to be greater than normal. Since women will lose blood during menstruation, HMB can be easily be confused for normal blood loss. The thing here is it should be heavier or much more frequent. So a good question would be how often they change pads. If it is double or triple, it might be a sign of heavy menstrual bleeding. So some conditions to eliminate. Occasionally, medicines can change menstrual bleeding patterns. If an ADR is suspected, then the patient should contact the pharmacist, and the pharmacist should report this to the prescriber as such, or could be referred. Additionally, the incidence of menstrual pain is higher in patients who have an intrauterine device fitted. Other conditions to be crossed out should be endometrial and cervical carcinoma. This is characterized by inappropriate uterine bleeding, usually in postmenopausal women. So if a menopause woman is bleeding, it is a point for referral. Evidence-based for over-the-counter medication, there is only one drug you can give. In this case, it is tranexamic acid. So ito po yung ating pampampat ng dugo. So tranexamic acid has been in clinical use for approximately more than 30 years, and it can reduce blood loss by 50%. Just take note that tranexamic acid should be taken once the bleeding starts. Dose is 2 tablets 3 times a day for a maximum of 4 days. The dose can be increased to 2 tablets 4 times a day in very heavy menstrual bleeding. Maximum dosing is 4 grams daily. Side effects are unusual, and most common is your mild nausea, vomiting, and diarrhea. So that concludes our lecture on our women's health. Hopefully, you may help someone in the future when you practice in the community pharmacy. I hope that you put these lectures you learned today to good use.